thank you for the organizers for inviting me. I'm very impressed in this by this design auditorium. I'm also very pleased of sharing the floor with Donna and Anne, who have been an inspiration for all the professionals who see these patients and the families. So I'm just going to briefly discuss how you try to implement all the guidelines from a practical point of view. I'm going to there's a lot of overlap with what has been said previously, but nevertheless I'm just going to hammer on the issues that I think are relevant. Okay, so it's been said that it's a multisystemic condition, consistent pattern with variable severity of the features and presence at different ages. It causes a significant morbidity during lifetime, and it requires multidisciplinary management. The whole idea is that the early diagnosis and effective treatment of any associated problems, will improve the general outcome. So in real life, I love this advertisement of the Max Appeal, which probably sort of illustrates, all this, the multisystemic nature of this disorder. And it says, Adam looks like any other 9-year-old boy, but what you don't see are the 16 conditions that make his life with 22q11 so challenging. And indeed, and these are only 11 of them, these are sort of, the usual trajectory that any person with 22q1 deletion may have to go through in his childhood, right? So some general considerations. One thing is that it may present in different ages with different medical problems. We are all aware about the importance, the relevance of congenital heart disease. Ultrasound echography has improved significantly in the last years, and many of these kind of truncal congenital heart disease are picked up prenatally. But sometimes these children, they show up in clinic, for different reasons, or referred by other specialists that have nothing to do with the heart. So the other thing is that also to take into account, and this has been mentioned previously, is that the medical, the educational, the social, and the neuropsychiatric concerns have different priorities at different stages of life. Initially, in infancy, the heart, the feeding, then at school age is the palate, and then the learning. Then when you when you get into adolescence, it's the social, the behavior. When you're an adult, you're more concerned about the social and employment issues. This is a very good slide, also has been shown by Donna previously, which shows, not just the relevance, but also the intensity of the interventions needed at different stages of life. Initially, obviously, if you have a heart problem, you need surgery, major surgery, prolonged hospitalization, many complications that go along with it. Then later on, the feeding is also important. Then later on, the speech, communication is more important. Learning difficulties, obviously the learning process it gets more and more sophisticated with age, so probably you'll need more help along the way. Other conditions such as endocrine conditions and immunological probably remain the same throughout life. So these are things that you have to supervise during your lifetime. And another aspect that I just wanted to mention is that there are sort of simultaneous and overlapping aspects of development. You can't separate speech from feeding, from growth, and you may need sometimes even the same specialist, a speech and language therapist, to assess a child who may have difficulties sort of, sucking and swallowing and chewing. So all these are ideas or just arguments to stress the need of a multidisciplinary approach, and also, you know, communication between the team of specialists that look after these children, as you are probably just too aware, because sometimes this is also a complaint that we get from patients, you know, that they have the feeling that specialists don't communicate very well with one another. So I think this is very important. And also another idea that has been mentioned is the need of somebody in charge of the healthcare of the patient. There has to be a management coordinator, you know, to facilitate communication between the specialists and also to ensure that there's adherence to the guidelines. It is also important to involve family members and other specialists, non-health specialists, that are part of the children's world, you know, school teachers, because school is a really important dimension in the development of an individual, and also non-health specialists such as social workers and occupational therapists. The other thing that has been mentioned again, and I just want to hammer on this, is the idea of transition, right? So you, as a child, you grow in a cozy, well, relatively cozy hospital environment in the way that, you know, the specialists have seen you growing and they know you by the name, you know, they enjoy to watch the child grow, and so the child, you know, is somehow familiar. Sometimes yes, they see many specialists, but they have, you know, it's a familiar environment. Maybe you wouldn't like to be too familiar, but nevertheless, it's like a familiar environment. Nothing compared to the cold sitting waiting room of an adult clinic, right? And just precisely, you have to do this jump, you know, in adolescence, when there are a lot of physiological changes, you know, character changes, a strong social pressure. So it's probably not the best time to do it, but, you know, that's the way you know, health systems are organized. And so it is important, you know, to ensure a smooth transition, particularly to avoid gaps in care. So the guidelines have been developed based on consensus of experts. They are guidelines in the way that we have different sort of health systems across the Atlantic. So you have, you know, the guidelines that were developed by Philadelphia and the Toronto group with other European colleagues. But then, you know, the British developed guidelines according to different methodology and trying to adapt the recommendations to the health system. No big difference. What is important is that these are guidelines, and it really, you know, it's not a question of, you know, going to your doctor, you know, just with a chart and saying, I just want to make sure that I can tick all the boxes. I mean, each patient has, or, you know, his or her own individual needs. So it's really for the specialist, you know, sometimes once he has assessed the patient, you know, to see what sort of follow-up and management the patient needs. More recently, guidelines have been developed for adult patients. As we're seeing, you know, it's sort of increasing proportion of 22q11 individuals. And these guidelines take into account, well, similar sort of full medical and neurocognitive assessment, but other issues that have also been discussed about, you know, health, sex, and internet safety, the possibility of substance abuse, as a way also to try to prevent sort of, you know, psychiatric complications, and the early detection of signs and symptoms, you know, that could herald psychiatric illness. So after all this, what do we do when we see a child and the initial diagnosis of 22q11 has been made? We do obviously a full physical examination, just to double check surgery investigations and counseling to the parents. We request a full cardiac examination, but even if the child, you know, apparently hasn't had any heart problems previously. Depending on the possible palate problems, if there's some clinical signs, we request an assessment by the palate team, and I'll get back to that later on. If there are no concerns, if you have a child, an infant who is apparently sort of sucking well, eating well, no nasal reflux, you know, the palate looks apparently normal, we just keep an eye on him or her, and then just refer systematically to the speech and language therapist by the age of 2. But again, I mean, this is just what we do in real life in a setting. We obviously request a full immunological examination with the investigations. In infancy, we refer them to neurology because the neurologists usually sort of are in charge of arranging early intervention, physiotherapy, and so on. But this is the way we work. If we have a child, a school child, older with no apparent neurological signs, we let psychologists and psychiatrists look after them. We do endocrine investigations, obviously, to assess the calcium, the thyroid. we request a renal ultrasound. Ophthalmological assessment, it depends. If there are no concerns, we just wait, and definitely we will do it by the age of 3. We do refer all children for neurocognitive assessment at the age of 3, which is just by the time you start preschool education. We are very fortunate to collaborate with a neighbor, with a neighbor hospital, a team of child psychiatrists. We've been collaborating for 7 years now, and it's been extremely rewarding and fruitful for all of us, obviously including the families and the patients. And then just the additional oral health, we check other problems and manage them as appropriate. So what we do, we have a general consultation of sort of for the coordination of care. You know, for the first 2 years, usually we arrange appointments every 3 to 6 months. It really depends on the situation of the child and the parents. I think our impression is that, you know, sometimes we are there just to support and to make sure that all the things are checked. The other thing is that sometimes also you have to do all these investigations and referrals sort of stepwise, you know, because otherwise, you know, patients can be sort of overwhelmed by a dozen of different referrals to different specialists. So we try to, you know, to do it gradually. But usually by 2 years, 3 years of age, if things are sort of, you know, already assessed, and we usually do a follow-up. We see them every year, and then until age 6, and then again, you know, every 1 to 2 years, depending on the progress. For immunology and endocrinology, I think we refer them right away. This is very important also. We'll discuss it later. But usually they arrange review appointments every 3 to 6 months for the first 2 years, and annually thereafter, also as needed. Cardiology, palate, speech, ophthalmology, others, again, you know, depending on the findings of the initial assessment. Psychology, psychiatry, we refer them at the age of 3, as I said. They have their own sort of schedule for the assessments, and according to any sort of problems, they arrange the follow-up as needed. So for the sort of getting into the sort of the condition specifically, it has been mentioned, for the child that has been diagnosed prenatally or shortly after birth, standard medical and surgical treatments. Be aware of the specific, perioperative care and possible problems. From then on, there's a lifetime surveillance. If a child shows up with no apparently heart problems, normal sort of auscultation, no signs, we nevertheless request a full cardiac examination and the management follow-up as needed. If the heart is fine, you don't really need to look it further. Again, it's been mentioned, the women with a deletion who want to have a child, they need to be assessed about, the risks for them, for the fetus, for all the obstetric complications. And these are really high-risk pregnancies that should be managed in a specialist hospital unit. The palate, I think it's very important that there should be a team of specialists, usually speech and language therapists, surgeons and ENTs that are coordinated and have experience with 22q11. They need to be aware of the peculiarities of the pharynx and the dynamics of the palate, and they have to have experience operating these children. For the overt cleft palate, usually the standard management, and maybe you need some further operation later on in school age. For the velopharyngeal insufficiency, it's important to have first an assessment of the speech. Again, depending on the gap, there is sort of an individualized treatment plan. There are various techniques. There's no consensus on this, and usually the specialist does what works best for his patients. This is usually done around the age of 4 or 6. Additional considerations regarding this situation, just to check for the displacement of the carotids, and you should get an MRI before surgery. There's the concern about the cervical instability. We'll later get back to that, and also check for calcium. And if sometimes you do too good a job trying to close the gap, you may have sort of sleep apnea. So it is also important to check this post-operatively. For the immune system disorders, it's important to have an early assessment to provide guidance for the live viral vaccines. Regular follow-up, it's arranged by the specialist, usually, just to check all the different cell counts, immunoglobulin levels, and so on. Usually this improves later in life. Autoimmune disease sort of takes over in a way, and this is also something that needs to be sort of followed up. Just to mention, there's increased risk of allergies and celiac disease, which is the experience of all of us. So the endocrine disorders, the early detection of hypocalcemia and thyroid dysfunction, particularly at times of biological stress. The growth assessment Donna has just mentioned, it's unusual to have sort of growth hormone insufficiency, but usually sort of investigations are just as needed, just to check the growth velocity, the bone age, etc. With feeding and gastrointestinal disorders, again, depending on the problems, an early full assessment by a speech and language therapist. If there's more than usual, maybe, as Donna has just mentioned, you should require, just an assessment by a GI specialist. Just investigate any swallowing problems, so dynamics of the esophagus, and possible discoordination of the pharynx and so on. So again, feeding problems tend to improve. It's a bit unusual, that the problem is so severe that it needs sort of gastrostomy, but usually you may need tube feeding, if particularly in the first years if there's a heart condition. Genitourinary anomalies, we start with physical examination and then just a renal ultrasound. We see we're using the same slide from the internet, and just to mention the risk of the building of calcium in children that just have a single kidney if you want to treat hypocalcemia. Scoliosis, it's very common, and I think this is important. It behaves as the asymptomatic idiopathic scoliosis, which probably develops in adolescence, and you need to screen for this. Some people advocate an X-ray by the age of 9-10 years. That really depends on different teams. The cervical spine anomalies, there's cervical instability. Again, some people advise or recommend flexion extension X-rays at the age of 4 to 6 years, and other keep an eye on it and just warn anaesthetists about the possibility of cervical spine injury if you're manipulating the head of a child under anesthesia. Just hearing and vision, again, if there are concerns. If there are no concerns, again, you still you need to arrange ophthalmological examination at the age of 3. I know I need to finish just. And so for the oral health, again, it's very common. It's very common. It has no correlation with other conditions. Just all you can do is be aware and be in regular contact with your health team. So just the final word on expert centers. Ideally, you would like an expert center, a multidisciplinary clinic where everything under one roof, all the appointments in one day, the cases personally discussed between specialists, maybe a common database, clinical database. It should include transition to adult care and the coordination with education and medical social services, but in real life, maybe you end up with different hospitals, separate appointments. The cases discussed not always as well as we would like. And the transition to adult care, not brilliant, and the coordination with education and social services, again, lacking. So, in summary, I think that we've mentioned the multidisciplinary care, the need to be coordinated by a designated professional, the guidelines available, individualized management plan, the early detection and the neurocognitive assessment. But I think we still need to improve the transition and adult care, and I think also we need to improve coordination with education and social services to ensure a better quality of life for these patients and social integration in adulthood. Thank you very much.